Welcome everyone to our July WebEx as part of our monthly WebEx series focusing on transitions, omissions and high-risk medicines as part of the SPSP medicine program. And it's an absolute privilege today to be able to welcome some of our international colleagues and for those of you who were able to attend the Medicines Reconciliation Summit in March, both presenters today, Jane and Brenda, were able to come across from Northern Ireland and be part of the summit. And so it's an absolute privilege to be able to have them both now part of our WebEx series, but also sharing today on what they've called quite smartly, I think, human steps on the giant's causeway of medicines reconciliation. So again, welcome everybody, and particularly welcoming Brenda and Jane for their time today. So just a few points for the WebEx, and as our host has already pointed out, if you have joined the WebEx and not yet dialed in, please make sure you do use the phone lines to dial in. The passcode on this is an example. You'll have the exact passcode to use as part of the diary invite for today, but we have had people join WebExes in the past and not able to hear the audio content. So if you are able to join, that's fantastic. As you've mentioned already too, all of the lines are automatically on mute, but we will be opening the phone lines towards the end of the WebEx to have a question and answer time with our presenters from Northern Ireland. So please do have your questions ready. But in the meantime too, we want you to get involved, and as people are already getting involved on the chat box, please do select all participants from the drop-down menu and send a message to everybody. If you do select other options, it just means that not everyone will be able to see what you've typed, and we're really into open, all earn and all share. So please do that. And there's already a bit of a start, so people who have joined, can you please use the chat box just now to introduce yourself, let us know where you work and what your job title is, and that would be a great way to make sure that we can all use that all participant chat box. So please do. Just as a reminder, the SPSP Medicine team is a small, perfectly formed team. We've got Arvind Varaya, who's joined us on the WebEx today, and in the room with myself today is Janet Heritage and Kirsty, and my name's David Maxwell, the Improvement Advisor for SPSP Medicines. The WebEx series for 2017 follows on from the WebEx series we hosted in the previous financial year, where we really focused just on reducing medicines harm across transitions. For this year, our priorities still remain on transitions, but we're also looking at omissions and the broader concept of high-risk medicines. And it's fair to say, as our program's progressed, we've really come to learn that all of these things are quite interlinked. So we've purposely broadened our topic series for the WebEx of 2017-18 to encompass all of these areas. And throughout the year, you'll be hearing from a number of international guests as well as local boards about the improvement activities they've undertaken within these three key areas. So we do want to keep people engaged, and so I'd like to ask Sarah to open and introduce the polling question for today, please.
Thank you, David. Ladies and gentlemen, your poll will open shortly. And just let you know, if you can please choose of which of the following professions best describes you. You've got A, medical, B, nursing, C, pharmacy, or D, other, and please type that in the chat box. Thank you. Please make your selection now.
So thank you everyone for taking the time to answer the poll. We're really keen to use this information just to give a broad idea of the types of people we're engaging with. Oh, I've just got a prompt here. Yes.
The poll is now completing.
Thank you very much. We're just waiting for the results of that polling to show, which will be appearing on the right-hand side of the screen for everyone to see. And while we wait for that, we can progress through, and you can see here today, we've got a majority of people identify themselves from the pharmacy profession, about a quarter of us are telling us that they're something else besides medical, nursing and pharmacy. So welcome, and it's great to have a broader representation of people on the call today. So without further ado, I would like to now hand over to our guest colleagues, as well as I've mentioned before, both Jane and Brenda. I'll let them introduce themselves. once the ball's been passed. But again, they're here to share their improvement journey around the human footsteps on the giant causeway of medicine's reconciliation. So thanks, Jane and Brenda.
Thank you, David.
Thank you, David. Hello everyone, and thank you very much for inviting us to speak today. We thought we'd put the picture of the Giant's Causeway up. We're working for the Northern Ireland Tourist Board really, and on commission from them, so it is a lovely part of the world. But I think it's something, it is quite relevant to this topic because it's an area that's been around for a long time, and I think medicine's reconciliation is also an issue that's been around for a long time, and it's one that there is no obvious end or solution to. So what we want to do today is really just give you an overview of what we're doing in Northern Ireland, and at the end maybe get some ideas from yourselves about how we can progress. Before we start then, just to kick off, my name is Brenda Bradley. I'm one of the many pharmacists on the line today. My background is originally community pharmacy, then academia, and then for the last 20 odd years I've worked for the Health and Social Care Board in Northern Ireland. My main areas of responsibility would be around governance really around community pharmacy and general practitioners, and then also medicines management issues as they relate to GPs and community pharmacists as well.
My name is Jane Agnew. I'm the Clinical Pharmacy Manager in the Southern Health and Social Care Trust. So we're in the southern end of Northern Ireland, about 25 miles south of Belfast near Newry, and we're quite a rural trust. There's 5 trusts in Northern Ireland. We do have the advantage that a lot of the things that we take forward, we take together as a country rather than individual trusts. So that has helped us quite a bit in developing medicine's reconciliation. I was going to give you a wee bit of the background on where we've come from and where we are now. So in Northern Ireland, there was a medication safety collaborative in 2008, and that's when we started looking at medicine's reconciliation. Each trust started to develop medicine's reconciliation forms, and it was multidisciplinary. We also had collaboratives where we met and we shared how we were progressing. And at that stage, each trust would have had maybe 1 or 2 wards, and we would have been collating data on 10 charts every week to see whether medicine's reconciliation had taken place. However, over time, it became more and more pharmacy dependent, and pulling the charts became harder because it was asking pharmacists to do something extra. So we actually moved to the pharmacists recording their step in medicine's reconciliation. So now what we do in secondary care is 1 week every month we measure clinical pharmacy performance indicators, and part of that is medicine's reconciliation. We automatically exclude day cases, but for all other patients we record the percentage of our admissions where a pharmacist has undertaken medicine's reconciliation at admission, and the percentage of those admissions that have been done by the pharmacist within 24 hours. We also then record the percentage of discharges with pharmacist medicine's reconciliation. So unfortunately we're only capturing pharmacists, we're not capturing the multidisciplinary team. We've also tried to make it more multidisciplinary. We train F0 doctors, they come out from Queen's University. The problem with F0 training is not all the doctors will end up, we train the ones that are on our placement in our trust, but they might not end up in an F1 post in our trust. And we also will get some F0 doctors coming from universities on the mainland, and we usually do follow-up training for them when they start in August. We also do F1 induction, but one of the drawbacks is we don't get induction for our F2s, SHOs, Regis, so if they haven't worked in our trust before, they might not be familiar with our paperwork. We're involved with pharmacy undergraduate training through our teacher practitioners in both universities in Northern Ireland, University of Ulster and Queen's, and they do training in medicine's reconciliation with the students. Students come out in placement to the hospitals, and they actually get to do medicine's reconciliation as part of their placements. And then we've developed with our postgraduate education NICPLD, which is the Northern Ireland Centre for Pharmacy Learning and Development. We've developed a medicines management accredited programme for hospital pharmacy technicians, and one of the modules within that is medicines reconciliation stage 1. All pharmacists or all trusts would now have technicians trained to do medicines reconciliation. We've only been doing it for about 3 years, so we don't have all our technicians trained, but we have a proportion. And I know in our trust we have found that that does help, especially at weekends if we have a technician working who can do medicines reconciliation. And what we have found is over time, as they become more experienced, they actually will move forward into stage 2, where they actually will flag up the problems to the pharmacist and help them prioritise. We also are working towards getting all our Band 7 and above pharmacists trained as non-medical prescribers. And the reason for that then is whenever medicines reconciliation is done, they can make changes of omissions, wrong doses and so on. So the problem is fixed immediately rather than having to wait for a doctor to fix it. If there's anything that they have any doubt about, that they're not sure, they have to speak to the medical team first before correcting it. One problem we have found, NIECR has been a wonderful development, but speaking to medical staff, they assume that it is a live document of patients' medications. We've done some work in our trust and then in the Northern Trust about looking at the accuracy of the NIECR, and this is data that came from, it's one of our pharmacists whenever she was doing her master's project, and she looked at the accuracy of the NIECR over 2 years, and what we find is it's only accurate for about 60% of your patients. For between 40 and 50%, things have changed since that drug was supplied, and then you can't rely on it being accurate. So that's one of the problems with the medical staff using the NIECR without another source, is that for 50%, around 40 to 50% of patients that will fail. Different reasons. Most common reason is that a drug has been stopped maybe by the GP, but the supply was maybe a month ago by the GP practice, but they've stopped it within the last 2 weeks, and then that doesn't show on the NIECR.
So I suppose just to illustrate some of the difficulties that Jane has talked about, we just wanted to take you quickly through a case study. So this is a 72-year-old lady called Kathleen. Kathleen has been living independently socially and managed by her GP in the main, but has been admitted to hospital with community-acquired pneumonia. Sorry,
click again. That one.
Sorry, technology problems here. So whenever Kathleen was admitted to hospital for her treatment, she didn't bring her medication into hospital. Obviously, we would encourage patients to do that, but that will not always happen, particularly if it's not a planned admission. The admitting doctor used only the NIECR to write the medicines Cardex. Obviously, we would encourage a second source of information to be used, but that can be challenging, and as Jane's already mentioned, a lot of GPs or a lot of the medical doctors in the hospital will assume that the NIECR is accurate. The NIECR is literally a download or a dump of all the medications that have been prescribed for Kathleen in the last 6 months. It doesn't give any indication about why the medication has been started, and it doesn't give any indication about if things have been discontinued, and it's also not clear if someone's on a couple of different strengths of tablets to make up one higher strength. That won't immediately be obvious either. The other challenge is that if the patient hasn't been prescribed it in the last 6 months but is actually still taking the medication, so it could be that they've been given a prescription for a longer period than 6 months, or they haven't reordered it because they have a bit of a stockpile at home. That won't show up in the ECR either. So all of those really are challenges and will present difficulties if only the ECR is used to write up the medicines Cardex. So in Kathleen's particular case, she actually was receiving 60 milligrams a day of furosemide, and that was made up of 2 different strengths, 20 milligrams and 40 milligrams. The doctor incorrectly assumed that she had been taking the 20 milligrams, which had then been increased to 40 milligrams, and then only prescribed the 40 milligrams, resulting in her getting less than she should have. The other issue then is that the medication up to Johnson had been stopped, but because it's literally a download of what has been prescribed, it doesn't show up that it's been discontinued on the ECR. So it was stopped 2 weeks ago, still on the ECR, so the doctor continued to prescribe it for Kathleen when she was in hospital. The errors then remained undetected until the pharmacist did a medication history and reconciliation with Causeway and NIECR. So you can see the difficulties really associated with this, and if there isn't proper medicines reconciliation carried out, those changes can carry through the whole way through the patient's stay in hospital and then on to discharge. The GP in community can assume that those changes have been made in hospital and then continue the patient as they have been treated in hospital. So you can see there's the potential there to perpetuate the errors if you don't have the correct processes in place and if only one source is used. The next slide then that you can see is a very busy slide, and apologies for that, so not expecting you to interpret it in any level of detail. Really what we wanted to show you was just some of the data that we're now starting to collect from across the trusts. Jane mentioned at the start that there are 5 trusts in Northern Ireland, so each of these individual charts illustrates the data that is coming back around medicines reconciliation from those 5 individual trusts. Jane mentioned that the data is collected 1 week in a month. That information is then sent through to us in the health board, and we collate that and really can then start to map out and see patterns and profiles. We've really only, I suppose, got to grips with getting the data collection processes sorted out, so we don't have data going back very long. You can also see just at a glance that there are some gaps. If you look at the chart, the bottom left-hand corner, there's a couple of gaps there. So for whatever reason, the information hasn't been sent through from the trust to the board, so we haven't been able to capture that. You can see when you look at it that there are peaks and troughs, and those peaks and troughs really are reflective of the fact that pharmacy resource is limited. There will be some wards that have got one pharmacist. If that pharmacist happens to be off sick or on annual leave, there won't necessarily be cover, so very little medicines reconciliation will be done during that time period, so you may see then a fall off. You'll also see different patterns across the 5 trusts, and that really is reflective of how they, well, number 1, recruited their pharmacy workforce, and then number 2, how they choose to use that. We do see differences across the 5 trusts in the resource that they've been able to invest in pharmacy staffing within the trust. Some will have more than others, and will have profiles where they can have more input to medicines reconciliation. Also, some trusts will have decided to invest more heavily in certain areas and ignore other areas. Others will try to cover all areas. So again, you'll see different profiles coming across. I think one of the key things to note is that the level isn't really changing. You know, although there are peaks and troughs, it is relatively steady, and we're certainly not seeing any huge increases or decreases. And we've really come to the conclusion that, you know, we are doing as much as we can with the resource that we currently have, and if we are to see an increase in medicines reconciliation, we will either need more pharmacy resource, which I think is unlikely, or we need to think about how we can do it differently, and as Jane said at the outset, how we can start to bring in other healthcare professionals to the process and really get other people involved to do that. I mean, I suppose one of the really obvious things with only having pharmacy involved is that there isn't 24/7 cover, you know, so it can't be done at all points of the day and the week, you know, and again, to drive that figure up, we would need to have that cover across more of the week, which would mean bringing in different professional groupings to support us. I just wanted to say a little bit about primary care. I mean, Jane at the outset talked about the history in secondary care. Medicines reconciliation has been around in secondary care for longer. Primary care, it really hasn't been on the agenda in a formalised way. The GMS contract did have the need for medication review to be done by patients or for patients until quite recently. There was an indicator there that they were expected to carry out medication review for high-risk patients, but certainly in Northern Ireland that indicator has gone as a standalone entity. There is an assumption that medication review will be carried out, particularly for those risky patients, but it doesn't always happen, and because there's no need to demonstrate it, we can't assume that it will always happen. And medicines reconciliation will have been done in different ways by different people at different points in time. So again, we don't really, up to the minute, we haven't had a clear medicines reconciliation process that we could truly stand over. In Northern Ireland, in the last 12 to 18 months, we've had a considerable investment in primary care. So all GP practices will have a practice-based pharmacist in the next few months. We've done it through 3 rounds of recruitment, and wave 3 has just concluded. So I think the last practice will have somebody by sort of September, October. We've over 330 practices, so it's a considerable investment and a considerable resource. There are a number of key objectives that they will have to meet and satisfy in order to keep the funding going, and 2 of those are on the slide there. To carry out 90% of clinical medication reviews at least every 12 months for those patients on 4 or more repeat meds, care home residents and frail and elderly. And then, for the purposes of today, the important thing is to complete 100% of medicines reconciliations within 5 days of receipt of information associated with patient discharge. So I think that is a huge step forward in us getting medicines reconciliation onto the primary care agenda. And, you know, it's something that pharmacists we know are good at, and I think they will be a real asset in the practice to make sure that that happens. I think one of the challenges we'll pick up later on is we don't want that medicines reconciliation happening in primary care in isolation. You know, we do need to link back to secondary care if there are particular issues, and there will be additional, you know, the resources in the trust who will be expert on medicines reconciliation. So we really just need to develop those relationships and the arrangements to make sure that medicines reconciliation is done as well as it can be.
I'm going to tell you a wee bit about NIECR. So I should have said at the beginning, NIECR is our equivalent of your ECS, but it's the same right across Northern Ireland, whereas I think you have variations between boards. There are developments with the NIECR. Up until recently, you only could see GP-issued medicines, and now it hasn't happened yet, but it's coming this summer, where we will be able to see hospital-issued specialist medicines, so the likes of erythropoietin, the likes of enoxaparin, things that are supplied by hospital only, that before wouldn't have shown on the ECS or ECR, and the risk was a patient came in on this, we didn't know they were on it unless they could tell us verbally, and the drug was omitted. So we tried to give you a screenshot of what that will look like. There will be, where we have a choice of choosing GP medications, there will also be a point where we can choose hospital-supplied specialist medicines, and in the screen will show any hospital specialist medicines there. So the examples in the screenshot shows either tretinoin, anabolone, ketamine, enoxaparin. The red line just shows if a drug is returned, so you can see if for some reason maybe a patient has stopped, or if there's been any compliance or adherence issues that they've returned the drug. Also coming in NIECR, sorry, I haven't moved on. Sorry, I should have said around that as well, with the red list drugs, not all medicines will come across, some will still be hidden. So HIV drugs will still be hidden, chemotherapy drugs, trial medications and fertility treatment will be hidden, and that's just around patient confidentiality that they're not going to show in the NIECR. This is another new development. Again, we haven't got a date yet for this, but we hope by the end of the year we will have medicines reconciliation in NIECR. And it will be, it's been sold to medical staff that if they do medicines reconciliation in NIECR, that will be exported into an electronic discharge that will be available in NIECR as well. At the moment, each trust has their own electronic discharge, and the medicines have to be manually inputted, and that's always a bugbear with medical staff, as it's the bit that takes the longest to do. So this is their carrot, is that if they do the medicines reconciliation at admission, it will help them at discharge. So whenever you go into patient's record in the NIECR, there's a medication button, which you can see circled in red there. And when you go into that, you will then select to do a review, and you'll see medication that's in the patient's repeat list. You can also then import recent acutes and get the full list of their medication. And then what you'll do is go through each medication, and you'll do a review, and you'll actually have a medicines reconciliation button that you have to press to say whether the drug has been continued, withheld, changed or stopped. Once that's completed, it's saved, and once it's saved, it then will feed the discharge. So another, if a doctor has done this at admission, and the pharmacist comes along, they can't change what the doctor has done, but if they find that there are things that aren't 100% right, they can then start their own medicines reconciliation, following on from the doctors. So you may have, for a patient being admitted to hospital, you may then end up with 2 medicines reconciliations, and it would be important at discharge that the doctor selects the right one for the discharge letter. So this just shows you the previous medications that the patient was on, and once they've been reviewed, what the list shows. And you can also then compare your MedRec. So this would show somebody comparing a MedRec from hospital to one that was done in community 22 days ago, and you can compare them. But this is both, as I was saying, that we need to be careful that when the discharge is generated, that they select the most up-to-date one and not an old one. Another advantage with this will be that we'll be able to generate patient reminder charts. We've tried using ones in JAC, but they haven't been very user-friendly, but this will actually allow us to do it through the medicines reconciliation function in NIECR, so to actually give patient more information on discharge of what their medication now is, so that they're not continuing to take something that has been discontinued or altered in some way.
Okay, so I suppose really the last couple of slides we just want to talk about some of the successes and challenges, and then also you know, next steps. So I think from our perspective as a success, we can say we've got standardisation within pharmacy across the 5 trusts. You know, by and large, and obviously taking into consideration everything that I've said about staffing levels, but we are using the same processes, recording in the same way, and feeding into the same system, so we can see patterns and start to identify where some of the problem areas are. Getting the practice-based pharmacists on board, I think, is a key success as well, and I think it will very much help to ensure that medicines reconciliation isn't purely secondary care facing, that it's also going on in primary care, which is crucial because that's clearly where patients spend most of their time, and very important for those patients who are in and out of hospital, and also if they're moving from one GP practice to another or into different, maybe a care home, something like that. And then the NIECR, I think, has been a huge step forward. You know, it obviously comes with some difficulties. It's not 100% perfect, but it certainly is a massive step forward to where we would have been 4 or 5 years ago, where it was all very much paper-based. And the challenges, I think we've already sort of talked about some of those, but just to summarise, we are struggling here in Northern Ireland to try and get any level of multidisciplinary involvement. It is very much pharmacy, and you know, even at the minute we're trying to get more pharmacy technicians involved, but we also need to think about then how we get medical staff sold into the process, and you know, start to think about champions and how we get them to move it on. Confirmation of NIECR with a second source, in theory, should not be very difficult to do, but it's making people aware that it is crucial to do that. It may cause a bit of a delay in the system. You know, so for example, if you have a patient who can't really communicate terribly well, who's admitted late at night, the community pharmacy won't be open, so you really only have NIECR and you may not be able to do anything until the morning. But really just reminding people continually that that second source is crucial, otherwise you do run the risk of errors, as we've both already said. And the challenge then as well, that if you spread your clinical pharmacy service very thinly, you will start to see the patterns that we can see in some of the trusts at the minute. So again, important to get other groups involved. Next steps then, well, we need to get the NIECR electronic discharge package that Jane described up and running and out, and obviously with that will come a lot of training requirements, not just as a one-off but on an ongoing basis as we get new F0s, F1s in, and new pharmacy students coming through as well. We need strategic support for medicines reconciliation, and I think that's one of the things that struck Jane and I when we were over at the summit, was the fact that you had representation at the event from a lot of your chief officers across Scotland, and they seem to be very supportive of it. It seems to be there in policy for Scotland, and that's something I think we need to work on here in Northern Ireland. we need to make sure that the IT support and enablers are there, and really future-proofing it and making things as simple as possible for all the staff. And particularly if we do want to record, we want to make recording simple, because the more difficult it is to record, the less likely people are to engage with it, and then we really do struggle to know where we are. Staff resources, we've already said about getting other staff involved, the pharmacy skill mix, but it's also then about making sure that primary and secondary care join up, that it isn't seen as two separate silos of working. And then a big thing is training. So across all levels, and not just when things come out that are new, it's ongoing training. And one of the things we think would be important is compulsory e-learning, where people have to do something as a refresher, possibly every 2 years, because things will change, staff will change, etc.
So things that we would like to learn from others. If anybody has been able to crack it, making it multidisciplinary, please, would love to hear from you. And on the day of the summit, there was discussion at the end, and one of the things was about not doing medicines reconciliation for patients who are in hospital. I think I should say less than 48 hours rather than only doing it for patients who are in hospital for greater than 48 hours. Quite often when somebody's admitted, you have no idea how long they're going to be in. We would say if they're being discharged the next day and you haven't done medicines reconciliation, you don't do it. You just look at the ECR and do a quick check for interactions. But if somebody's been in 24 hours, we would be targeting them for meds rec. So the 48-hour bit I find a bit difficult to know how do you actually figure that out in practice, unless you're waiting to the point of discharge. So if anybody could explain if they are doing that, how they actually do that, that would be great. I'm going to try and pass back, I think, to David now, hopefully.
Jane and Brenda, thank you so much for providing an overview of the MedsRec experience in Northern Ireland. I think you've touched on so many aspects of, I think, some of the challenges that are being faced in Scotland as well, and I think you've probably heard of those as well when you're over at the summit. It's fair to say the chat box has been very lively. I don't know if you've had a chance to have a look while you're presenting. It's always a bit of a challenge for me personally anyway to do both, but it's fair to say there's a lot of chat and there's a lot of questions coming through. So I'd like to, first of all, thank you both, and I would like to now open the lines. So Sarah, would you mind opening the lines to allow for question and answers? But can I ask for all the participants to try and minimize any background noise that might be around you, just to allow the conversation to flow freely. And while we're scanning the chat box for some of the key questions, I'd like to invite Arvind, our clinical lead, to sort of open with some of the key questions and reflections.
Thank you, David, and thank you, Brenda and Jane. That was really very helpful. Very helpful run-through of lots of work, and it was really good to see what you're able to do with the NIE ECR, stuff that we can't imagine doing with ECS right now anyway. So there are lots of questions, but can I just ask two burning questions that I have? The first one is, just so we understand how your work relates to what we are doing, what are the criteria for good medicines reconciliation that you are following? And the second question for me personally is, when you spoke about pharmacy students on placement doing medicines reconciliation, I think, Jane, you mentioned that. Does that mean they were prescribing as well, or was it that they were auditing medicines reconciliation?
With the students, but I'll answer that first. The students will actually go and do a drug history with the patient and then compare that to the Cardex. That's a form of medicines reconciliation they're doing. So we're actually teaching them the process.
Right.
Queries with medical. From an early stage, how to do a history and to undertake medicines reconciliation. So it's not an audit and they're not prescribing. They actually have to go to medical staff, and they would always be under the supervision of the pharmacist. The actual criteria for medicines reconciliation, our aim is that we do medicines reconciliation for every patient admitted except for day cases and renal, and maternity patients are excluded as well. The problem with doing just the pharmacy-only data is if you have a ward that doesn't have a pharmacist, we don't.
Sometimes your WhatsApp ones are family chat and stuff.
Sorry, we've just seemed to have some interference on the lines there. We've just dropped off to hear the end of your response to that question. I'm really sorry. Would you mind just to answer again in terms of the criteria, please?
That's okay. No, the criteria is any patient that is admitted, but we exclude renal patients, maternity patients, and day case patients. But as I was saying, a problem is if we have a ward that doesn't have any pharmacist cover, we don't have any figures for the medicines reconciliation for those wards. Have done some projects. An example in our trust was our PEDS wards didn't have a pharmacist, and we got winter pressures funding, and we put in, unfortunately they were junior pharmacists that we got funding for, but we then were able to get some MedRec data and get some intervention data where you could see where things had gone wrong previously without a pharmacist being present.
Brenda, just to check, so you mentioned the group of people on whom you would do it, but is my understanding right that you say medicines reconciliation has been done if the medicines are 100% accurate, or they should be only, so when everything is done accurately?
Oh, right, when we say MedRec has taken place,
yeah.
We would actually say it's at the point the pharmacist finishes, although the Northern Trust would do that differently. They would say MedRec is not complete until the changes have been made on the Cardex, whereas the other 4 trusts do it, it's up to the point that the pharmacist has taken it. So you may still have things that a doctor hasn't yet addressed. So that maybe skews some of the figures slightly. It's not exactly the same across.
Because let's say a pharmacist sees a patient for whom NIECR is available, you've looked at it, patient is confused, you can't really confirm with the family or carers. Presumably that would not count as MR compliance, or am I?
No, that wouldn't.
So it'll have to be, yeah.
So we would say they have to use 2 sources. We always would ask who looks after the medicine. So usually if a patient is confused, we would try and contact a family member and find out who looks after their medicines at home and use them as a second source. But it's rare we get somebody that you can't get a second source to confirm with.
Yeah, yeah. Thank you for that.
And thank you for that. And I think some of the data that you presented as well around the accuracies of your NIECR I think are quite compelling. So we thank you for making the comparison to it being similar to the ECS. And I think there are equal concerns in Scotland around the accuracy of the ECS. And I think the data that you've provided would just ensure or reassure the importance of actually going to that second source. So thank you for that. Now, I know that there have been a number of questions, and I'm not pretending that you've probably had time to actually go through the chat box while we've been chatting just now. But I know also that Angela, your colleague from Northern Ireland, has also been doing a fantastic job at answering quite a number of the questions as well. So Angela, can I be so rude as to call upon you? Are there any reflections or comments that you would make in terms of the questions you've got through in the chat box today as well? Sounds like Angela, are you online? No, it doesn't sound like it. Okay, we'll go back to that. But there have been a couple of questions if we can work backwards. And I think Angela has actually said that perhaps Jane or yourself, Brenda, would be able to answer this. But it's around the options of excluding specific medicines. What seems to be a fantastic intervention of making the hospital only medicines available, but choosing to exclude specific medicine groups like HIV medicine, chemotherapy, etc. So the questions around have been asked, have patients actually requested this to be not made available? What grounds did it come up to actually make that decision to not show them?
Some of it's from the systems that are used. So the chemotherapy, how it's been fed into NIECR is from JAC, and we're working at one, I can't remember the name now, the chemotherapy system, so that's going to be a different computer system. So the feeds aren't there, the problem there. HIV, I'm not sure whether it's actually been a patient request, and that could be why. And I know with the fertility clinic that we do, it's sometimes understanding what stage the patient's at in their cycle as well, because you actually can make wrong decisions if all the information went across as well. But I don't know if that's definitely been a request from patients, or that doesn't appear.
I'm not sure. Don't know. It's certainly something we can look into, you know, and come back to you. If we come back through you, David, if we can certainly look into that and come back with a bit more information, even just a bit in a written format, and you could share that with us.
That would be fantastic. I think someone, and I apologise because there is so much chat, but I think Anne Thompson, if you're able to speak, I think you raised the question quite early on around some of the exclusions that are being suggested around probably some of the most risky in terms of interactions and side effects.
Yeah.
Yeah. Yeah.
So, Anne, did you want to expand on that, or do you think we've covered that well enough?
Can you hear me okay?
Yeah.
You might need to pick up just a little.
Yeah, no, it's just a question, because I think sometimes we create stereotypes and assumptions around certain diseases and drugs, and I just wondered, because I've heard the same up here with not putting certain things on the right-hand side of our prescriptions and stuff like that as well, when we've tried to add hospital-only drugs onto the GP systems, but as outside-only drugs. And I just always kind of wondered if that was something, like why that was a blanket rule, because if it's a patient-centred approach, it should be about individual consent rather than blanket assumptions. I was just interested in where some of these blanket decisions come from, because as you say, there's risk around showing some things and not others, and people understanding what's shown and what isn't shown. To me seems more risky.
You can't come in just a moment.
Thanks for that. I guess from a Scottish perspective, we're really keen to get people's thoughts around something that I don't think anyone is able to do within our boards at the moment, and that's combining the primary care prescription information with the acute or the hospital-only medicines. I think that's something that people have identified within Scotland being a significant weakness of our emergency care summary, because it is only primary care-based information. I'm just wondering, are you able to comment on how that information is being drawn together? You've mentioned a couple of electronic systems like JAC, and you've obviously got a primary care prescribing electronic database, but how is it that you're actually able to pull the two sources of information to be presented on the NIECR?
We're not the techies behind this, to be quite honest. There's been quite a bit of work to get the red list drugs where they've been able to take that from JAC, because previously we were reliant on GP surgeries putting those on manually, but then they dropped off after 6 months. So that was the reason why they made the decision to pull it from JAC, but I don't know enough about the technical background to that, to be honest.
And so when you're mentioning JAC, that's an electronic prescription administration system for acute hospitals. Can I ask how widespread is the implementation of HEPMA or JAC across Northern Ireland?
Every hospital in Northern Ireland uses it, so that's why we could standardise.
Wow. Okay. So you've probably got an appreciation. We've got a staggered rollout that's been planned for a while, but we are in no way in the same position as you in terms of the rollout of HEPMA being at that extent at this point in time. So I guess that's probably where we could look to in the future. I'm just conscious, the lines are open, so are there others on the call that have any specific questions or comments to Jane and Brenda about the information they've shared today? I'd really be keen to have this opportunity for you to ask away.
Can I, this is Arvind again. Hi, David. So if I can make a comment and ask a question of the audience as well. Very interesting point you made at the end about medicines reconciliation only for people who stayed for over 48 hours, and that sounds like a complex thing. What we aim for, at least where I work right now, is that we try and do medicines reconciliation for every patient within 24 hours of admission. The question about whether we do medicines reconciliation or don't do for people who've stayed for less than 48 hours comes up in a group of patients who come to acute admissions. Admission MedSrec, it's the same plan. We try our best to get at least 2 sources, et cetera, and do that. But at discharge, we won't re-prescribe the drugs in the discharge summary. You won't record every one of them at the time of discharge if the patient has stayed for less than 48 hours and there has been no change to the medicines. I don't know whether that's the kind of question you were asking. Was it Brenda who mentioned that? But perhaps that's the closest I have to something where we don't do something related to medicines for people who are there for a shorter stay. And I wonder whether there are other people in this WebEx who also have experience of having a different process for people who stay less than 48 hours and over 48 hours.
So as chair, I'm going to use my prerogative and name some people that I know who are on the call to see if they can give us some feedback on that. And I'm going to go to, first of all, colleagues down in Esh and Aaron. So, Pamela, are you able to comment about the practice around patients being in hospital for less than 48 hours?
Yeah, we still do exactly the same process, but I suppose from our perspective, transferring medicines onto the discharge letter is actually a very quick process when you've got HEPMA. And we would certainly be advocating that you need to include all the medicines on the discharge letter because of drug interactions and actually making sure the GP knows that medicines haven't been stopped. So yeah, we do exactly the same process.
Thank you, and thanks for that contribution. I'm going to go to our group from Grampian, who's cleverly called themselves SPSP NHSG. So I'm assuming that we know who you are, but are you able to comment in terms of Grampian's practice around medicines reconciliation for patients being in hospital for less than 48 hours? Oh, see, we've stunned them into silence. Sorry, Jane and Brenda. So Grampian colleagues, if you are there, please do jump in. I can see that you've logged onto the WebEx, so I'm hoping that you'll be able to comment. Deirdre, in terms of Tayside's practice, are you able to comment? I'm sorry to put you on the spot.
As far as I'm aware, David, I think it's just all patients within 24 hours of admission. I'm not aware of anything different to that. So as soon as they come in, could you hear me?
Yes, absolutely. Loud and clear. Thank you. That's fantastic. Are there any other people? I'm not going to pick on any more, but are there any other final comments, particularly around that question? No. One of the questions that Angela did answer during the WebEx, and I think it's a question that we're being asked quite often and a challenge that's faced at a number of boards, is community pharmacists accessing that type of information. Yeah. So Angela mentioned that there's pilot work happening at the moment for community pharmacists to access the NIECR. Are you able to expand on that a little bit further?
Just to say that yes, it is happening. At the minute, our community pharmacists have very limited access to anything electronic. They're all independent contractors and they've got their own email addresses and IT systems. But there's pilot work ongoing to try and get them to connect in through a portal which would allow them to see, all our information, alerts and so forth. The pilot then is also running, as Angela said, just to let them have a look at ECR. It clearly would only be the medication. They wouldn't be able to see any other information that's relevant to the patient. So not sure really of the time frame for that. Hopefully, into next year, all of these electronic developments for community pharmacists will start to roll out.
Yeah. And thank you for that. I think you probably would have picked up when we're at the summit, there's quite a bit of variation across the 14 boards in Scotland around the level of access at the moment in terms of electronic information to community pharmacy. So our silence from Grampian has been welcomed with a chat comment. So just to make sure that people who may not be able to see, Grampian have commented, as far as we understand, MedRec should be done within 24 hours. And they've dobbed in their colleague Lindsay may be able to elaborate. Having problems with speakers, so that's fine, but thank you for that. I am conscious of time in terms of wanting to make sure we do let people away by 4 p.m. We could probably continue chatting. I think the opportunity to learn from both a smaller system with the standardized electronic JAC rollout across the whole country is something I think we are quite envious of. And so I think we would look to you quite longingly to see how things progress. But I want to finish this part of the WebEx to say thank you both again for your time, and also for Angela's. I know we've had a bit of discussion with Angela as well about how we can collaborate and learn from each other moving forward. And I'm hoping from your perspective, both the summit and today's WebEx has helped support that for you as well as us. So thank you very, very much for your time.
Thank you.
Thank you.
Thank you.
Just before we finish, David, one of the questions we'd asked was how have other areas managed to get other professional groups involved? You know, as Jane said, it's very pharmacy heavy, very pharmacy focused for Medicines Reconciliation in the Trust. Has anyone any tips or good news or success stories as to how they've managed to engage other people?
Sure. Does anyone want to comment on that from local practice? I mean, if not, we can definitely continue this offline. We've got a number of boards where there are specific models of care where there is no pharmacy service at all, but Medicines Reconciliation is a key priority that they aim to do on all patients being admitted. So we can definitely share that with you. And I know Arvind would be more than happy talking to you as well about, in his capacity as the National Clinical Lead for this and being a medic. So he is quite passionate as well. I can dob him in. So we can definitely follow that up after this WebEx as well.
But just to add to that just now, I think the silence itself would have told you that I don't think people have solved it anywhere. There are places where particular activities are taken on by other professional groups as well. But I think making it a multidisciplinary activity, there are a few bright spots, but overall, it still seems that Medicines Reconciliation and at least the overview and giving the impetus for that seems to be primarily driven by pharmacists across Scotland, as far as I can see.
Okay.
Thank you.
Thank you.
So, not to cut all of this conversation short, but we do need to make sure we do give people the privilege of getting back to work on time. So thank you again for your time. And just to make sure people are aware, our WebEx is a monthly WebEx series on the third Thursday of every month. So next month on the 17th of August, we're going to be hearing from two separate presenters within GG&C. First of all, looking at a human factors side of medication or medicine administration errors with an initiative called Chance to Check. And we're also going to hear from some pilot work where they've been actually involved testing patients' self-verification of meds rec in the acute care setting, which I think is going to be quite interesting. And moving forward, in September, we're going to be focusing the next WebEx on high-risk medicines. And in October, on the 18th, we've got a number of boards that have agreed to present on work they've been doing to look at trying to reduce the rate of omitted medicines, particularly those to do with blank spaces, medicines being marked as not available in care settings. So we do hope that those are topics of interest for you, and please do share these and the schedule that's on our website with colleagues that might have a particular interest in high-risk medicines or omitted medicines. So we do hope to see you on the 17th of August, and as a reminder, the recording of this WebEx will be made available on our website, as have all the previous WebExes to date. So we do hope that you're able to share that link with your colleagues. Thank you again for your time, and we look forward to meeting with you again on the 17th of August. Thank you very much.